Hi, my name's Shannon McPhee. I'm an associate professor of emergency medicine at Dalhousie University, and I also work with a program called TREK, or Translating Emergency Knowledge for Kids. We're going to spend some time talking about diabetic ketoacidosis in kids. And starting off, we have a couple of questions. And so what I'd like you to do is record your answer, and we'll circle back to these at the end of the presentation. First question, the treatment of DKA in children includes a direct bolus of 0.1 units per kilo of insulin. So mark your answer as either true or false. The second question, severe DKA is defined as a pH of less than 7.2, ketonuria, and known diabetes. And that's either true or false. The anion gap represents the unmeasured anions in the plasma and is greater than 12 in DKA. Please write down the calculation for anion gap. A patient who presents with a pH of 7.25, a bicarb of 9, blood glucose of 18, and ketonuria meets the criteria of DKA. After a 10 cc per kilo bolus of normal saline and 1 hour of IV fluids, insulin is started at. So the learning objectives for this are to describe a new fluid management for pediatric DKA that's being used throughout the Nova Scotia Health Authority and the IWK Health Centre, and to think through a couple of complex DKA cases. You're going to see lots of patients who come into the emergency environment who have diabetes, and they may have hyperglycemia, but it's important to choose the right subset of patients before entering into a protocol. And to meet the definition of DKA, you must have three things. You must have acidosis, as defined as a pH of less than 7.3 or a bicarb of less than 15. The second thing you need to have is ketones, either on your urine test or a ketone meter. And the third is that you need to have either known diabetes or a random blood glucose of greater than 11.1. So if you have all of those three things, you're in DKA, and all of the treatment regimens here are meant to restore your metabolic abnormalities back to normal in a safe, controlled way. It's important to know how sick that patient is in front of you. And we would divide up to mild, moderate, and severe. Patients with severe DKA have pHs of less than 7.1 or bicarbs of less than 5. Moderate, less than 7.2 or a bicarb of less than 10. And mild DKA is defined as a pH of less than 7.3 or a bicarb of less than 15. And important to understand that, as if you're working in a more remote location, the severity level should indicate to you that you may need to call life flight earlier. You may need to look for a higher level of care. One of the things that's been different about adults and kids with DKA has been the incidence of cerebral edema. So that's really the most feared complication, and it almost exclusively occurs in kids. So about 99% of cases of cerebral edema in DKA occur in children under 20. And it's because of that risk that's made the pathways for adult and peds DKA so divergent. And so starting back in the 1980s, we had uncontrolled case series that showed us that kids who received greater volumes of fluids in those first 4 hours had higher rates of cerebral edema. And so as a result of that, we used to think about huge osmotic shifts happening because of rapid fluid infusions leading to increased ICP and cerebral edema. But over the last decade or two, we've really questioned that, as we often see kids who actually present and come into the emerge environment already showing signs of cerebral edema who haven't received any fluid therapy at all. What's been really helpful was a recent publication by Cooperman in 2018 that performed a randomized controlled trial of almost 1,400 kids with DKA. All of these kids received a 10 cc per kilo normal saline bolus, and then these children were randomized to have their fluid replaced either in the fast group, so those kids received a second 10 cc per kilo bolus and received fluids such that they were replaced over the first 24 hours, or a slow group where the deficit and the maintenance were replaced evenly over 48 hours. And the goal of the study was to help us understand whether there were any adverse neurological consequences as defined as a declining GCS in these children. And there was no difference in neurological outcomes. And this has allowed us to recreate protocols to use more fluid and more quickly in the past, but it's still not adult amounts. So this is still, the protocols that have been released across Canada are still very controlled. It's just a little bit more liberal before. And so we'll talk about the new TREC-based protocol by going through a couple of cases. So the first case is a 13-year-old girl who has type 1 diabetes for the last 5 years, and she has an insulin regimen and a meal regimen that she's not always compliant with. And so over the last day and a half, she has complained of nausea and vomiting, which are very common signs of DKA. And when she comes, her temperature is 37. This young girl is tachycardic with a heart rate of 130. She's tachypnic with a rest rate of 35. Her blood pressure is stable at 92/55, but she does have delayed cap refill and cold feet. She's had an accurate weight measured in your emerge department, and her Glasgow Coma scale is 14. Recognizing that she's at risk of DKA, you order blood work, and what her blood work shows is a pH of 7.04, bicarb of 3, she's got a glucose of 60, and she's got ketones on her urinalysis. And so thinking back, we've defined anything less than 7.1 pH as being severe DKA, so she has got a severe DKA. And we start to look at a few things. We need to correct her sodium, and the calculation is there, and that is normal. And one of the surprising things is that the potassium is 7.3. Now, we would expect somebody who has DKA to have a total body deficit of potassium. So we know that there would have been osmotic diuresis of many of those electrolytes. And so this is a little bit surprising. But it really, at this point, is a lack of insulin that's holding that fluid there. And the glucose is also very high. So this relates to the lack of insulin, but it probably also reflects a degree of dehydration as well. One of the learning outcomes was to learn how to calculate the anion gap, and so is the measured sodium minus the chloride minus the bicarb. And so for this particular patient, it is 127 minus 95 minus 3, and that equals 30. And that's really what we would expect. So we would expect children with DKA to have a anion gap of greater than 12. And that's something that we'd encourage you to calculate on an hourly basis as your blood work comes back as a measure of severity of illness and direction of how you're going with things. So the first step in treating this patient is to look at signs of cerebral edema. And at this moment, the patient has a GCS of 14, there's no headache, her level of consciousness is okay. And so that tells us that it's okay to follow a standard part of the protocol and provide a 10 cc per kilo bolus. And we would give that normal saline over 30 minutes, the maximum of 1 liter. And if she's still showing signs of hypoperfusion, we would administer a second 10 cc per kilo bolus. So that's the new part that we hadn't had in our protocols before, was to administer those boluses, again, with careful monitors and IV in place. And once the boluses are done, you need to think about writing a maintenance order. And so this is a rehydration table, and it's based by weight. And so for a child her age, because she is greater than 40 kilos, you would administer 4 mils per kilo per hour of normal saline, maxing out at 250. And your initial choice of IV fluid is going to be normal saline for at least that first 6 hours using that table. But when your glucose starts coming down below 15, or if you're noticing drops more than 5 millimoles per hour, you should add and change your fluid to D5 normal saline or D10 normal saline to prevent complications of hypoglycemia. And if the patient has been managed with their diabetes for more than 6 hours, so hopefully on a ward location, we would expect you to switch that fluid to half normal saline later in the course. The next part is the insulin. And so what you'll notice here is that we've given IV fluids for the first hour, and then we're talking about insulin. Insulin boluses are not necessary and in fact contraindicated. We expect the patients to be started at an infusion of 0.1 units per kilo per hour. Many places in this province have smart pumps, and nurses are able to enter that order knowing what the patient's weight is, and they simply enter 0.1 units per kilo per hour, and the machine will do the math for them. In the past, we've had maximum of 5 units per hour of insulin, and there's no longer any maximum. So for example, if a patient was 70 kilos, they could be running at 7 units per hour of insulin. So these things have been accomplished in our patients. So they received 2 10 cc per kilo boluses. They've now been started on their insulin. And when the blood work comes back, you'll notice that the pH has come up a little bit to 7.08. The bicarb moved from 3 to 5, so coming up a little bit along the way. We're maintaining a stable corrected sodium of 144. And you'll notice that the potassium has come down a lot. So just with the administration of fluids and also the administration of insulin, which forces potassium into cells, we're now seeing that potassium come down. And so once you see the potassium in the normal range and that you've demonstrated that the patient can void, you should add 40 millimoles per liter of potassium chloride to your IV fluid as well. Again, when you kind of come back and check in with your patient, you'll notice that the vital signs are coming down quite nicely as well. One of the things that can happen over DKA care is hypoglycemia, and so these are really a list of the more common complications that can happen during your treatment with DKA. Hypoglycemia would certainly be the most common, and that's the reason for the recommendation of adding dextrose to your fluids when the glucose is less than 15 or is dropping quickly, so more than 5 millimoles per liter. Hypokalemia is also common because the total body potassium is low, and that generally doesn't occur until that 4 to 6 hour mark. But again, we'd like to be ahead of that more than anything else. As a result of these and other electrolyte abnormalities, including low phosphate, very uncommonly the patient could have an arrhythmia, and for that reason patients should be on a cardiac monitor. But the one complication we wanted to spend a little bit more time talking about is cerebral edema or cerebral injury. And you can recognize that in your patient by a new or worsening headache, a level of alertness that's decreasing, and in very late cases, you may notice Cushing's triad or declining GCS. If this happens, you need to rush in. You're going to raise the head of the bed 30 degrees. All IV fluids need to be decreased to 60% of that volume in the table that was displayed earlier. And then you've got a choice. You can either provide mannitol, 0.5 to 1 grams per kilo, or 3% saline. And this is a patient that's going to require a higher level of monitoring, and so we generally would recommend 1-to-1 nursing care at this moment. One of the things that you'll notice that's missing from this is we do not need to rush into a CT scan. So the immediate management is decreasing the fluids, elevating the head of the bed, and providing either mannitol or 3% normal saline. We can catch up in a couple of days when the patient's more stable with head imaging, but it's not a requirement from an emerge perspective. And so this patient will go on to have their fluids replaced over the next 24 hours and hopefully uneventfully go home. So we'll move on to case number 2. And what you'll notice about this particular kid's blood work is the pH is 7.18, so in that moderate range. The bicarb is 5.3, glucose is 19, sodium 132, potassium is 4.9. And what's different about this particular case is even though the acidosis is in the moderate range, that initial blood glucose is not very high, and you may find yourself in this kind of setting where you have a diabetic at home with an intercurrent illness that might be receiving some boluses of insulin, but not enough to clear the acidosis. And so knowing that one of the complications of DKA treatment is hypoglycemia, I would absolutely start this kid out at a lower insulin rate. So I would half it, and I would start at 0.05 units per kilo per hour. And I would consider individualizing care for this particular patient. And this fluid I would start at D10 normal saline to start with right out of the gate. The goals of treatment for any child with DKA are to slowly correct the hyperosmolality and acidosis, to have a slow, controlled fall in your glucose. We expect that your corrected sodium be fairly constant, and we know that with the addition of fluid and insulin that our potassium is going to fall by that 2 to 4 hour mark, and so staying ahead of it and making sure that potassium is part of the maintenance fluid line is critical. To wrap up, we'll go back to our questions. The treatment of DKA in children does not include insulin bolus. Expect slow return of glucose and our other metabolic parameters, and we use an insulin infusion, not a bolus. The second question is in terms of definition of severe DKA. Severe DKA would be defined as a pH of less than 7.1 or a bicarb of less than 5. And so this patient actually was moderate, not severe. The third question was on the anion gap and the sodium minus the chloride minus the bicarb. And in DKA, we would expect that to be greater than 12. And the insulin infusion rate is usually started at 0.05 to 0.1 units per kilo per hour. So in conclusion, the treatment of DKA is complex. It is critical because this is detail-oriented work to use a protocol, but you will be required to use thoughtful decision making as the individual presentation of that patient may need change along the way. The treatment of DKA is complex, and we highly recommend the use of a protocol as the management is so detailed, but it's important that you continue to be thoughtful about your decision making along the way.